I would like to introduce our speaker and transition to the CE portion of the program. Cindy Lowen is a registered and licensed dietitian. She is a certified nutritional support clinician and also holds the credential of certified clinical research professional. Cindy received her Bachelor of Science from Western Kentucky University and completed her internship at University of Kentucky. She currently is employed by Nestle Health Science as the Medical Affairs Manager. She is also on the faculty at the University of Louisville School of Medicine. She has co-authored numerous publications in respected journals such as JPEN, Critical Care Medicine, and Gastroenterology. She has an extensive clinical background and has done numerous presentations. Please join me in welcoming Cindy.
Thanks, Debbie. I'm happy to be with you today. Thank you for this opportunity. So let's get started. So nutrition therapy is an important part of the overall medical treatment provided to critically ill patients. And enteral nutrition therapy itself represents a primary therapeutic intervention designed to achieve metabolic manipulation. For this reason, the topic of feeding the critically ill patient warrants familiarity of the nutrition literature and an understanding of the published guidelines developed to direct clinicians in appropriately feeding the critically ill patient. So at the completion of this presentation, you will be able to identify the benefits of early enteral nutrition in the critically ill patient. You will be able to describe obstacles to appropriately feeding in the critical care setting. You'll discuss methods for nutritionally supporting the ICU patient per the 2016 ASPEN SCCM guidelines. And then you'll be able to review recent pertinent critical care nutrition literature. For the first time ever, the authors of the 2016 Critical Care Guidelines created a bundle. The actual guidelines themselves comprise a 52-page document, but the bundle is a simplistic overview of the guidelines, so to speak, with 6 practice statements, and we'll go through each of these practice statements over the next hour. So why did the authors create a bundle? Well, the Institute for Healthcare Improvement developed the concept of bundles to help healthcare providers more reliably deliver the best possible care for the patients undergoing specific treatments. So a bundle is a structured way of improving the process of care and patient outcomes. A bundle's power comes from the body of science behind it, a collection of science-based practices that when used individually, they're not as strong as when used together. So you really shouldn't cherry pick just one statement from the bundle to use. You need to use them all together. The first statement in the bundle is to assess patients on admission to the ICU for nutrition risk, in addition to calculating both energy and protein requirements to determine the goals of nutrition support. There are 2 separate validated methods for assessing patient risk in the 2016 Critical Care Guidelines. They include the NRS 2002, which you see here on the left side of your screen. That was created for the European Society for Parenteral and Enteral Nutrition. And then the Nutrix score on the right side of your screen was created created by the Canadian Critical Care Nutrition Society. The NRS 2002 was developed by Condrup and colleagues in Europe. It was developed with the assumption that the indications for nutrition support are severity of undernutrition and increase in nutrition requirements resulting from disease. This tool is easy to use, it's practical, it's been validated to identify those patients who are going to benefit from nutrition intervention, but it doesn't categorize the risk of malnutrition. In this simplistic tool, a high-risk score is a score of 3 or greater. The other suggested nutrition risk scoring tool is this Nutrix score tool on the right side. Again, disease severity and nutritional status are assessed with this particular questionnaire. This tool has been validated with and without IL-6 as a variable. If IL-6 isn't used, high risk is defined by a score of greater than or equal to 5. The modified Nutrix score, excluding the use of IL-6 as a variable, was further validated in this post-hoc analysis of the REDOX randomized controlled trial of ICU multi-organ failure patients. A total of 1,199 patients were analyzed, and they found that there's a strong positive association between nutritional adequacy and 28-day survival in patients with a high Nutrix score. High risk is depicted by that red bar you C here and the low risk by the blue. And you can see the dramatic increase in 28-day mortality in that high-risk patient if adequate nutrition is not provided. So the concept behind the use of nutrition risk scoring is that not all patients derive the same benefit from nutrition. The ICU is a mixed population of patients with varying degrees of illness and nutritional status. If a patient's well-nourished, not severely ill, there may be little benefit from aggressive nutritional support. However, if that patient is malnourished and critically ill, there's a benefit from feeding as well as an urgency to feed these patients. And I think more importantly, they may be more than likely be harmed by underfeeding. Part of the first statement in the nutrition bundle is to assess calorie and protein requirements. Indirect calorimetry remains the gold standard for calorie assessment. If indirect calorimetry isn't available, then you can use predictive equations. The author suggests that the equation of 25 to 30 calories per kilogram per day for the patient with a BMI below 30 is as accurate as any long drawn-out predictive equation. Same holds true for obesity, that 11 to 14 calories per kilogram actual body weight per day for BMI of 30 to 50 and 22 to 25 calories per kilogram ideal body weight per day for a BMI of greater than 50 is as accurate as a long drawn-out predictive equation. Protein requirements are discussed numerous times. Over 10 protein recommendations are made in the 2016 guidelines, and we will talk a little bit more about protein later in the presentation. A4 of the guidelines suggests that based on expert consensus, ongoing evaluation of adequacy of protein provision should be performed. And so this is just an example of a tool that was created, and it's housed at www.enactnutrition.com. This particular tool is a data collection form that you may be able to implement in your facility to track how much protein is being provided, because we know that we can prescribe as much protein as we like, but if it's not being delivered, it's not going to do the patient any good. So I encourage you to look at the different critical care toolkits at this Enact Nutrition website. The second statement in the Nutrition Guidelines bundle instructs us to initiate enteral nutrition within the first 24 to 48 hours following the onset of critical illness, and to increase to goals over the first week of the ICU stay, not the first day, but the first week. This is consistent with brand new ESPEN guidelines that were just released at ESPEN this month in Madrid, Spain. They suggest early full feeding should not be used in critically ill patients until days 3 through 7. Of course, if you look at the data that we have showing how we feed in the U.S., we do well to try to get to a calorie goal by day 7 anyway. So what's driving these recommendations? The U.S. ASPEN SCCM recommendations use studies through December 2013. They just had to have a cutoff date to look at the different studies, and it took from December 2013 until January of 2016 for the guidelines to be published. Since the 2013 date, we've had multiple studies published. We've had the Harvey study, the PANIC trial, the Patel study, the Nuturia 2 trial that just came out this year, the INTACT study. So numerous trials have been published, and many of these looked at feeding adequacy using a combination of parenteral and enteral nutrition, and they found that underfeeding may be beneficial unless malnutrition was evident, and supplementing with PN was not so helpful, especially during the first week of ICU stay. So while the guidelines give a structure for nutrition care of the patient, it's important for us to stay apprised of the current nutrition literature to drive our actual practice. This is a slide I borrowed from Dr. Stephen McClave. He is a gastroenterologist out of the University of Louisville and one of the authors of the guidelines. And he says that there appears to be a number of reasons why we want to be cautious that first week with calorie delivery. And the 5 reasons that he provides us is, first, there's a risk of bowel ischemia, and that's that patient with hemodynamic instability that we're going to be very cautious feeding anyway. Overfeeding in the ICU can occur easily, so we need to be careful, watch signs of hyperglycemia and overfeeding, and feed accordingly. Maybe we need to provide a feeding that's higher in protein and lower in calories. We need to look at risk of refeeding syndrome, especially in those patients who have hypophosphatemia. That's documented prior to feeding. Of course, we want to normalize that prior to feeding. Underfeeding supports autophagy. I think the jury's still out on that, but that's another reason why you want to be cautious that first week. And then by starting up and being cautious the first few days of feeding, you can gauge tolerance as that infusion is increased. So why do we try hard to provide early enteral nutrition in our ICU patients? There are numerous benefits to providing early enteral nutrition to the critically ill patient who's unable to maintain volitional intake. Providing early enteral nutrition supports structural and functional integrity of the gut, as well as allowing modulation of the stress and systemic immune response and attenuation of disease severity. Whenever I look at the different organs in the body and how they relate to nutrition, I get excited and I think, oh, this might be the most important organ in the body. No, this is the most important organ in the body. Well, I look at the structure and function of the gut, and I am convinced today, right now, that probably the gut is the most important organ in the body. And you can't really look at the structure and function of the gut without examining those intestinal epithelial cells. And so what are the intestinal epithelial cells exactly, and why is it so important to preserve the structure and function of these cells? Well, the intestinal epithelium is the largest of the body's mucosal surfaces, and it covers about 400 meters square of surface area with just a single layer of cells organized into crypts and villi. The intestinal epithelial cells play a major role in digestion and absorption of nutrients and immunity, and it provides an impermeable barrier to undesirable elements of the external environment. So the gut protects us from the outside world. Intestinal epithelial cells mature into one of four major specialized cell types. Specialized intestinal epithelial cells that maintain the digestive and barrier function of the epithelium include, first of all, the enterocytes, and that's the majority of the intestinal epithelial cells. These release enzymes for digestion and absorption of nutrients. Then you have the enteroendocrine cells. These cells form the basis of the largest endocrine system in the body. They secrete hormone regulators of digestive function, and in turn, this controls our motility. It acts as a first-line component of the brain-gut axis. It controls appetite and controls receptors for sweet and bitter tasting, which I think is amazing. Then there are the goblet cells. These release mucin. They're responsible for that protective mucus blanket of the intestinal tract that prevents adherence of pathogenic bacteria. And then you have the Paneth cells, which release antimicrobial proteins. These intestinal epithelial cells, they're replaced every 5 to 7 days. And when you think about it, around 9 liters of fluid and 1 kilogram of nutrients are absorbed daily in a healthy gut. So this is driven by these epithelial cells, the epithelial transport. And it's a process that consumes lots of cellular energy and oxygen. So we have to protect this process, and we do that with early enteral nutrition. When the gut's not used, there's a loss of structure and function. So you have reduced blood flow, and this leads to reduced contractility, increased openings in the intestinal epithelial walls of cells. There's an increased bacterial load that permeates the gut. This activates macrophages and neutrophils, which increases oxidative stress. Most importantly, the degree of change in gut permeability correlates directly with the severity of the coexistent disease process. And the enteral route of feeding is more likely to favorably impact outcome parameters. I just wanted to share this diagram with you. This is a diagram that comes out of a 2014 publication from Martindale, McClave, Hyland, and Rice. And I think it gives a very nice overview of the nutritional and non-nutritional benefits of early enteral nutrition. The nutritional benefits are highlighted in the teal boxes and the non-nutritional in the magenta boxes. And you can see that the non-nutritional benefits of early enteral nutrition far outnumber the nutritional benefits. Now, as part of creating the 2016 Aspen SCCM guidelines, the authors did numerous meta-analyses. And this is a meta-analysis that they did of 21 randomized controlled trials comparing early enteral nutrition versus delayed enteral nutrition. And what they found was that provision of early enteral nutrition was associated with a significant reduction in mortality. The patients who received early enteral nutrition had 30% less risk of dying than those who received late enteral nutrition. Again, for these guidelines, the authors reviewed 13 randomized controlled trials comparing early versus delayed enteral nutrition in regards to infectious complications. And they showed that the patients who received early enteral nutrition had 26% less risk of infectious morbidity than those who received delayed enteral nutrition. More recently, a meta-analysis was published this year by Zhang and colleagues, and they looked at enteral nutrition versus parenteral nutrition in critical illness. This was a systematic review of 23 randomized controlled trials, a total of 6,478 patients. They looked at mortality, organ failure, bloodstream infections, and hospital length of stay. And while enteral nutrition was not shown to have an effect on mortality when compared to parenteral nutrition, it was associated with a 41% decreased bloodstream infection, and that's what you see here, the bloodstream infection forest plot, and a decreased incidence of organ failure and reduced hospital length of stay. So why do we provide early enteral nutrition? Well, I think the message is pretty clear. You give early enteral nutrition within 24 to 48 hours of admission, if possible, to decrease mortality and infectious morbidity. The third statement in the bundle suggests that steps be taken as needed to reduce risk of aspiration or improve tolerance to gastric feeding. This ties into guidance D1 that based on expert consensus, we suggest that patients should be monitored daily for tolerance of enteral nutrition. Inappropriate cessation of enteral nutrition is common in the ICU, secondary to intolerance. So we really need to examine intolerance secondary to gut dysfunction in the ICU and see if there are some preventive components that we can use. So gut dysfunction is a physiologic response to injury in the face of hemodynamic instability with lack of oxygenation to the gut. The integrity and the structure and therefore the function of the gut is challenged. Oxygen deprivation of the tips of the microvilli of intestinal epithelial cells lead to ischemic death of the villi, and this results in decreased digestive and absorptive capacity. Each epithelial cell can have 1,000 microvilli on its surface, an extension of that intestinal epithelial cell, and this increases absorptive surface about 25 to 600 times. With physiologic insult and ischemic death of the microvilli, digestive and absorptive capacity decreases, so we see those manifestations of this happening when we see malabsorption in our enterally fed patients. There are a number of theories for the origin of gut dysfunction associated with critical illness. This particular theory of ICU gut dysfunction was published by Sartado and colleagues in 2015. And here's how they describe this phenomenon. They say there's this first hit when splanchnic hypoperfusion accompanies critical illness. There's an effort to preserve blood flow to the vital organs, particularly the brain and heart. The second hit is decreased blood flow to the splanchnic circulation, causing ischemia to the gut. The gut mucosal barrier is disrupted. It leads to loosening of the tight junctions of the intestinal epithelial barrier, and it increases mucosal permeability. Luminal bacteria is allowed to enter into the systemic circulation. And then finally, the third hit and final hit in this hypothesis is this release of chemokines and cytokines into the mesenteric lymphatics. You know that this travels up to the left subclavian vein, it enters into the pulmonary circulation, and that's where we see ALI, ARDS, multi-organ dysfunction syndrome. The gut dysfunction of critical illness is manifested in our patients. It's altered motility. We see abdominal distension, decreased bowel sounds, diarrhea. There may be delayed gastric emptying, vomiting, high gastric residual volume. And lastly, gut wall inflammation occurs with the alteration in the intestinal villi, especially those tips of the villi. This is an area that's extremely sensitive to decreased oxygenation to the gut. And then we have decreased gut absorptive surface. Marianne Chapman stated in a 2015 publication that gut dysfunction is associated with illness severity and worse outcomes during critical critical illness. So the sicker our patient is, the better chance of gut dysfunction that we'll see in that patient. So what if we could have an easy biomarker of gut dysfunction? And I envision that sometime in the future, we're going to be able to do something like a finger stick like we do for hyperglycemia right now, a finger stick that will show us some systemic markers of gut dysfunction. This was an article by Patan and colleagues published in 2016. And they said that if you have normal gut function, you're going to have normal villi, you're going to have citrulline synthesis taking place, and there's going to be no intestinal fatty acid binding protein released. But the minute that villi gets damaged, you're going to see a decrease in citrulline synthesis and an increase in intestinal fatty acid binding protein release. So by doing a simple blood test, we should be able to see if in fact we have damaged villi. So I don't think this is available anywhere right now, but I think this is upcoming, and it might be a nice way for us to actually have something concrete that shows that we have gut dysfunction outside our typical symptoms of intolerance. An understanding of gastrointestinal dysfunction during critical illness is really pivotal when considering the best methods for delivery of nutrition. In this chart, you can see that up to 95% of critically ill patients experience GI symptoms of intolerance. The symptoms range from conditions of motility to malabsorptive disorders. So we can say that the majority of critically ill patients will have at least one gastrointestinal symptom during their ICU stay. In the 2018 Zhang meta-analysis that I showed you earlier, they found that GI intolerance was a common complication. Enteral nutrition is a risk factor for vomiting and diarrhea, and of course GI intolerance leads to inadequate energy delivery, which is also associated with poor outcomes. So what do the Aspen SUCM guidelines say about intolerance? The authors addressed intolerance. E4B suggests that mixed fiber for diarrhea in the hemodynamically stable patient be used. Avoid any fiber in the hemodynamically unstable patient, the one that you're probably not going to feed or just trickle feed anyway. And then finally, you want to consider use of small peptide formulations, which makes perfect sense as we're feeding a gut that's been damaged from oxygen deprivation and it has reduced digestive and absorptive capacity. This is a cost-consequence model that was published this year. It uses data from the 2015 Gunga Bassoon article to identify prevalence and incidence of GI intolerance in the ICU. The cost-consequence model here considered 100 patients, 31 intolerant per the Gunga Bassoon data, and 69 tolerant. Intolerance is associated with increased ICU length of stay and therefore cost. GI intolerance is an independent risk factor for prolonged ICU stay and death. In addition, GI intolerance is associated with frequent feeding interruptions and reduction in enteral nutrition delivery. Use of a semi-elemental is cost-saving if just 7% fewer feeding interruptions are seen due to GI intolerance. So you can think about use of a semi-elemental as possibly a good safe start feeding, which was introduced as a concept by Darren Hyland with the PEP-UP protocol. This concept of developing tools to help in the identification of gut dysfunction is not new. In 2001, Mark DeLagey and colleagues validated a malabsorption index. The malabsorption index consists of 6 questions that range from stool frequency and consistency to presence of serum markers of inflammation. Each question is weighted, and the total score quantifies the risk of malabsorption. In this small retrospective validation study, there was an 83% correlation between the malabsorption index and nutritional therapy that the patient was receiving and tolerating. I'd like to introduce the idea also of exocrine pancreatic insufficiency as a possible etiologic factor in gut dysfunction. This was a prospective cross-sectional study of 563 mixed medical surgical ICU patients who required early enteral nutrition and were expected to stay in the hospital for at least 3 days. All patients received a standard high fiber 1 calorie per milliliter formula, and of course patients were excluded if they had any disease of pancreatic insufficiency, pancreatitis, or drugs that altered pancreatic enzymes or intolerance that disrupted enteral nutrition infusion. And what they found was that symptoms of intolerance were significantly associated with exocrine pancreatic insufficiency. So when you look at this chart, you can see that out of 563 patients, they identified 191 with moderate exocrine pancreatic insufficiency and 103 with severe exocrine pancreatic insufficiency. Furthermore, the diagnoses that were most associated with the prevalence of exocrine pancreatic insufficiency included shock, sepsis, cardiac arrest, diabetes, hyperlactoacidemia, mechanical ventilation, and continuous renal replacement therapy. You can see from this chart that approximately 20% of patients on mechanical ventilation alone experience intolerance and possible malabsorption. Exocrine pancreatic insufficiency is not uncommon in aging adult patients, and it appears to increase with age based on this population-based cohort study that was done in Southwest Germany. 914 patients were recruited by the general practitioner for this study during their general health examination, which is offered biannually to older adults in Germany. Patients with a history of high BMI, diabetes, gallstones, or cholecystectomy showed no statistically significant association with the prevalence of exocrine pancreatic insufficiency, but age, and to a lesser extent smoking, showed a statistically significant increase in the incidence of exocrine pancreatic insufficiency. Because the average age in the MICU patient is about 60 years old, I think we need to be cognizant of the potential for exocrine pancreatic insufficiency and therefore potential for enteral nutrition intolerance in this patient, of patients in this age group. This is the Gunga Bassoon publication I referred to earlier. This is a retrospective analysis of data from the 2009 International Nutrition Survey, and they had this objective with the survey of determining incidence of enteral nutrition intolerance, and they looked at factors that were associated with intolerance. And you can see in the pie chart on the right of the page the different factors: abdominal distension, subjective discomfort, vomiting or emesis, and high gastric residual volumes. Gunga Bassoon and colleagues analyzed the data and found that those patients who were feeding tolerant received more calories and protein than those who were intolerant. Furthermore, the negative clinical outcomes, including vent-free days, ICU length of stay, 60-day mortality, and days to discharge alive, were all significantly worse in the feeding intolerant patients. Apache scores were almost identical for both groups, so you really can't argue that one group was sicker than the other. The Gunga Bassoon results really make us stand back and we ask, do tolerance and delivery of calories and protein really alter outcomes in critically ill patients? Based on the observational data, the International Nutrition Survey, Highland's group suggests that adequacy of calories is important. And this graph represents analysis from 7,872 patient charts that were reviewed from 2007 to 2009. This represents 335 ICUs from 33 countries. And this data set showed that increased calorie intake was significantly associated with lower mortality across all types of patients, body mass index, and in both medical and surgical patients. Benefit of increased caloric intake diminishes as caloric intake nears goal calories at 100% of prescribed amount. So really 80% of goal calories was the sweet spot in terms of decreased mortality risk. And caloric deficit and worsened outcomes, this isn't a new concept. Valet and colleagues showed us that outcomes worsened as calorie deficit increased, and we really saw the greatest deficit, according to Valet, usually during the first week of hospitalization. All right, so we've talked about calorie deficit. Let's move into the area of protein. What about protein? The authors of the 2016 Critical Care Nutrition Guidelines tell us that in the critical care setting, protein is probably the most important macronutrient for healing wounds, supporting immune function, and maintaining lean body mass. Why do we provide high protein in the ICU? Well, you have to remember the ultimate nutrition goal is to maintain lean body mass and to maintain the quality of muscle mass. We know that 1.6% per day median rate of muscle loss occurs in a mixed ICU population. That's about 2.5 pounds per day in a 70-kilogram person. We also know that greater protein intake is associated with reduced infection and lower mortality, and that muscle mass is important for short and long-term outcomes in the ICU. But the bottom line, as verbalized by Peter Weiss, is that there's no data to support a lower protein intake in our ICU patients. Why are protein needs so high in the ICU? Well, initially, it's the endocrine response to stress with the catabolic hormones driving muscle breakdown. You are all probably familiar with this diagram. We all saw it in our initial training in college. It shows that outside of starvation, catabolism of nitrogen excretion is elevated for up to 40 days following a physiologic insult. And if there's repeated insult, then that duration increases. So what is the sufficient dose of protein? This was a study published by Allingstrup in 2012. He looked at really sick patients, burn patients that had greater than 15% body surface area burns on a ventilator, and then patients with severe sepsis. They monitored these patients closely with indirect calorimetry and nitrogen balance. And they found that risk of death decreased by 2% for each gram of protein and amino acid that was provided, and that provision of protein was related to the hazard of mortality, and that observed mortality was 50% of the expected mortality. So they concluded that death occurred earlier in the tertile of patients with the lowest provisions of protein and amino acids. What is the sufficient dose of protein? Well, it varies according to the patient condition, of course. For most non-obese patients in the ICU, the protein recommendation ranges between 1.2 and 2.0 grams per kilogram actual body weight per day. Protein provision may be instrumental in preventing ICU-acquired weakness. ICU-acquired weakness is a bilateral, symmetrical muscle weakness that's not associated with pre-existing neuromuscular problems, and it's secondary to muscle loss in the ICU. Treatment for ICU-acquired weakness includes adequate protein in the diet and physical activity. It's important to combine both. What is the effect of protein intake on mortality? Well, the objective of this retrospective analysis of the 2013 International Nutrition Survey was to determine if greater protein delivery would be associated with lower mortality and shorter total time to discharge. So of 4,040 eligible patients in this survey, 2,823 stayed greater than or equal to 4 days in the ICU, and 1,584 stayed greater than or equal to 12 days in the ICU. And what they found was that those patients that received at least 80% of prescribed protein intake had associated improved survival in both groups. We know that early and adequate feeding is important in achieving positive outcomes in our patients. Does the quality of protein make a difference? Well, yes, of course. High biological protein and protein with a high net protein utilization score should be used. You can see here that whey protein scores highest per this bar graph. Whey protein is the supernatant of milk after precipitation of casein. Whey protein has a high protein quality score. It contains a high proportion of branched chain amino acids, about 26%. It includes leucine, which may play a distinct role in protein metabolism. Also of note is immunoglobulins in whey resist degradation in the intestinal lumen, and that helps modulate immune function. Cysteine is high in whey protein, and that is a rate-limiting amino acid in glutathione synthesis. Glutathione protects against free radicals and oxidative stress, so important to our critically ill patients. Whey is a naturally occurring prebiotic and helps with the growth promotion of bifidobacteria. Whey is antimicrobial. The peptides are antimicrobial. They survive passage through the stomach and arrive intact in the large intestines, and they can provide antimicrobial action in the intestinal tract, including binding C. diff and inhibition of the cholera toxin. Finally, whey protein is insulinotropic, and it's been shown by Power and colleagues to increase plasma insulin concentrations by 28%. And I'll share a couple of recent studies on the insulinotropic effect of protein with you, of whey protein with you. The other occurrence in our patients in the ICU is anabolic resistance, especially in the aging population. Anabolic resistance is defined as reduced stimulation of muscle protein seen in the aging muscle disuse and in disease states. Skeletal mass is a determinant of quality of life and survival. So to fight anabolic resistance, adequate protein must be given with physical activity. So really, our nutrition programs, we have to work with physical therapists as well and with nursing so that we are getting our sickest patients moving in some way or another, even if it just means manipulating muscles as they're laying in their hospital bed. So metabolism of protein is involved with much more than just prevention of sarcopenia and anabolism. It can also affect glucose tolerance. So this is one of the studies I said I would share with you on the insulinotropic effects of protein. This was a multi-center randomized open-label clinical trial with parallel design in overweight and obese mechanically ventilated critically ill patients who were prescribed 1.5 grams of protein per kilogram ideal body weight per day. Patients received either an experimental very high protein, 37% protein, low carbohydrate, 30% carbohydrate formula, or a control high protein formula that was 25% protein with conventional carbohydrate of 45%. The objective of this study was to describe the glycemic and metabolic effects of an enteral formula containing high protein in the form of hydrolyzed whey and low carbohydrates. And you can see the difference in protein content and carbohydrate content here on this table. The idea was to provide isonitrogenous altered carbohydrate and total calories to subjects randomly. Both groups received essentially the same amount of protein, achieving approximately 80% of expected protein goals, which was good. Total energy intake was maintained throughout the ICU stay at 18.2 calories per kilogram ideal body weight in the control group and 12.5 calories per kilogram ideal body weight in the experimental group. Subjects were enrolled from June 2013 to November 2016. 106 signed informed consent, 105 were randomized, and data was available on 102 subjects for intent to treat analysis. There were 52 control and 50 experimental patients or subjects. The average age was about 61, BMI 33. Apache 2 scores weren't statistically different, and the most frequent diagnosis in these patients was mechanical ventilation with acute respiratory failure, followed by sepsis and pneumonia. And the secondary endpoints that were proven to be significantly different was a decrease of 10.8% in average blood glucose. It was 126 on average in the study group, and the control group was higher at 138. There was a decrease in the mean rate of a glucose greater than 150 milligrams per deciliter. There was an increase in events with normal blood glucose of 80 to 110. There was no significant difference in the glycemic events below 80, even though the study formula was lower in carbohydrate. There was a 10.9% decrease in the number of times insulin was administered. And interestingly, there was an increase in alkaline phosphatase and carbon dioxide in the control group, which suggests overfeeding at an average of 18.5 calories per kilogram ideal body weight. So the conclusion of the study is that a very high protein, low carbohydrate enteral nutrition formula facilitates glucose control in critically ill, overweight, obese patients in a medical intensive care unit, and an increase in blood glucose levels between 80 to 110 milligrams per deciliter was observed, along with a simultaneous decrease in insulin utilization. The next study that I would just like to quickly review with you was also pertained to protein intake, carbohydrate intake, and blood glucose control. We know that a standard enteral nutrition formula worsens hyperglycemia in diabetic patients. So it was hypothesized that altering the proportion of macronutrients in a formula, increasing protein while decreasing carbohydrate, would improve glycemic response. So the objective of this study was to demonstrate that an enteral nutrition formula containing very high concentrations of protein in the form of enzymatically hydrolyzed 100% whey protein and low amount of carbohydrate would provide better postprandial blood glucose control relative to the use of a control diet that was very high in protein as well, but higher in carbohydrate and consisted of whey protein hydrolysates and intact casein. So this is a randomized crossover clinical trial of ambulatory adult subjects with type 2 diabetes. The primary outcome is glycemic response after a bolus of isocaloric amounts of two enteral formulas, the study formula and the control formula. And you can see from this very busy slide that there were 12 patients chosen to complete in this trial. Age range was 56 plus or minus 7 years, 6 male, 6 female, average weight about 99 with a BMI of 33. And what they found was that comparing the two diets, there was a peak blood glucose level higher in the group that received 45% carbohydrate versus the 30% carbohydrate. There was a significant increase in blood glucose within 10 minutes of receiving the 45% carbohydrate feeding. Even after 150 minutes, there was a significant difference in blood glucose between the groups. Overall, the maximum increase in blood sugar was lowest for the high protein, low carbohydrate group. There was a faster return to baseline blood glucose levels in the high protein, low carbohydrate group, and there was a clinical trend toward lower endogenous insulin production over time. So in conclusion, this study demonstrated that the differences in macronutrient composition, specifically carbohydrates, proteins, and fats, can exert a significant metabolic effect on blood glucose levels of subjects with type 2 diabetes. All right, so let's move on to the next statement. The fourth statement in the nutrition guidelines bundle is implementation of protocols. So the strategy of volume-based feeding was developed at the University of Louisville, and you see volume-based feeding implemented in protocols frequently. And I just want to go over the validation study with you. So this is the chart that was created at the University of Louisville, and you can see that the maximum amount of feeding that was to be allowed to be infused into the stomach is 280 mils per hour, small bowel 150. You are probably familiar with the PEPA protocol. Dr. Hyland took a conservative stand, and he made the limit in both the stomach and small bowel of 150 milliliters per hour. This particular validation study was published in 2015. It was done in the MICU. There were 57 subjects in the MICU at the University of Louisville. And these patients, there were 37 that were in the volume-based feeding group, 20 in the rate-based feeding group. They received about 25 to 30 calories per kilogram, or if indirect calorimetry was available, they used it. And you can see that in the volume-based feeding group, they were able to meet 92.9% of caloric goal, whereas in the rate-based feeding group, they met 80%. And you know, you're probably stepping back going, saying, oh wow, 80% is pretty darn good. And it is. They did a nice job of feeding in this unit, but the point here is that volume-based feeding allowed delivery of more calories than the rate-based feeding. You can also see here that there was a reduction in mean calorie deficit by 60% in the volume-based feeding group. So one of the protocols that you're probably familiar with is the PEPA protocol. The PEPA protocol is, you can find this either on a Critical Care Canadian website, or you can find it, you can get materials from your Nestle representative as well. In this particular protocol, there are different feeding options. You can be MPO in the most hemodynamically unstable patient. You start at 25 milliliters per day, and then you advance to goal rate somewhere in the second or third day after tolerance has been established. You use target feeding or volume-based feeding rather than rate-based feeding. You start with a semi-elemental solution and progress to polymeric as tolerated. You allow a higher gastric residual volume threshold, and you use motility agents as needed initially, and then you taper off. These are the different tools that are available, and again, you can go to their website at criticalcarenutrition.com, or you can ask your Nestle representative to help you access these tools. So how well do we feed enterally in the U.S.? This was a multi-center QI collaborative looking at the influence of PEPA protocol and nutrition practices in the U.S. And you can see that if you use a very high protein, low carbohydrate feeding as your initial feeding, you can statistically significantly increase the amount of protein that's delivered when using it in a PEPA protocol. So the fifth statement in the nutrition bundle is to avoid use of a gastric residual volume as part of routine care, which is funny because you just saw that it's in the PEPA protocol. This particular recommendation was based on two large randomized controlled trials, the Montejo multi-centered randomized controlled trial and the Rainier trial. And in both of these trials, they were able to show that there wasn't an improvement in outcomes, there wasn't an improvement in GI complication rate if you used gastric residual volumes as a marker. So the suggestion is that you don't even use them, and you'll probably be more successful in providing calories to your patients by avoiding it. I just want to mention that some people do use gastric residual volume, however, as a marker of tolerance or intolerance initially in the onset of providing enteral nutrition. So again, this is by Marianne Chapman, and she suggests that gastric residual volumes are indicative of gastric emptying, and although they may not be indicative of pulmonary aspiration risk, they should be measured to determine the need for promotility agents and small intestinal feeding with the aim of improving nutrient delivery. So in other words, use it as a marker of tolerance. So and last but not least, I'll address the sixth statement in the nutrition guidelines bundle, which suggests that PM be started early when EN is not feasible, especially in high-risk patients. And you can see with this algorithm that Dr. McClave and I put together that you always want to use the gut if it's available. If it's usable, if you can't use the gut, then you want to consider TPN. You want to avoid it in the low-risk patient for the first 7 days of hospitalization, but in the high-risk patient, as soon as they're hemodynamically stable, then you want to proceed with providing parenteral nutrition, but it's important to have teams in place to help monitor these patients and use protocols. So in summary, assessment of nutrition risk is recommended to aid in determination of urgency to feed. You want to initiate early enteral nutrition within 24 to 48 hours of admission to the ICU, and you need to be especially careful in those high-risk patients to try to provide their needs as tolerated. You want to utilize protocols to aid in reducing the risk of feeding intolerance and to promote adequacy of delivery of feeding. You want to use parenteral nutrition as necessary when enteral nutrition is not feasible or adequate. And then I think most importantly, you have to respect the critical care nutrition guidelines and the work that was put into those guidelines, but you have to use clinical judgment at the patient bedside. You have to stay apprised of the recent evidence, and then you have to make your decisions regarding nutrition care based on all of those components together. And with that, let's see, I have a few minutes for questions, and I am happy to take any questions. Let's see, we have a question. We have a man in the ICU, 760 pounds. He's in the ICU with wounds. What do you recommend? He's on a vent. So a patient who is ventilator dependent in the ICU with wounds probably needs to have their needs met with some type of arginine-containing formula. I think that's extremely important. I think it's important to do indirect calorimetry on a patient who is of this amount of weight, and for sure you want to provide protein according to the recommendations from the guidelines. All right, I agree with increased protein needs. The chronic kidney disease patient, I think you need to, the question is, what about the patient with chronic kidney disease? Absolutely, you follow the guidelines for patients with chronic kidney disease. When a patient is critically ill in the ICU and requiring protein, and they're on hemodialysis or some type of dialysis, the goal is to meet their protein needs and dialyze as necessary. But when they get out of that critical state, then you need to follow the guidelines for chronic kidney disease. All right, the next question is, what do you recommend for a critical care patient with a gastric residual volume of 500 and enteral nutrition being held? Patient is on the vent and receiving continuous renal replacement therapy. Obviously, that patient, I don't even have to do the score, that's a high-risk patient. I think that it's important in a high-risk patient to get parenteral nutrition started. The guidelines suggest you hold lipids for the first week. I don't know if that's is really necessary if you have small lipid available, but certainly a soybean-based lipid you'd want to hold the first week. And I think you don't want to give up trying to give enteral nutrition, but obviously this patient with a gastric residual volume of 500 is probably not tolerating their feeding well, but boy, do you want to try to use that gut if you can with trickle feeds. All right. The next question is, aren't most formulas made using casein as a protein source? Or are these studies using supplemental whey protein? So the studies that I shared with you, the two insulinotropic studies that I shared with you were 100% enzymatically hydrolyzed whey protein. They were semi-elemental formulas. So yes, 100% whey protein formulas are available. Follow-up, do you base needs on PEN, adjusted ideal body weight, adjusted weight when a patient is 760 pounds? The guidelines suggest to us that we don't use adjusted weight. For somebody who's 760 pounds, you would follow the formula that's in the guidelines using ideal body weight. And that's for both protein as well as for calorie needs. And I think we probably have time for one more question here. If high gastric residual volumes are not recommended to be used to measure tolerance, what would be the best to determine feeding tolerance? Well, you have to do bedside physical assessment. You have to look for abdominal distension and monitor abdominal distension. You need to look at blood glucose control, look at their labs, see how they're tolerating the feeding. gastric residual volumes, I heard a really nice lecture by Beth Taylor a couple of weeks ago, and she was in agreement with Marianne Chapman that a few gastric residual volume checks initially, not every 4 hours, but initially, periodically, until you meet goal rate and establish tolerance is probably not a bad idea as just a marker for how that patient is tolerating the feeding. You need to look at other markers of intolerance as well. Always you look at their abdomen, you see if it's distended. If it's distended, you want to proceed very cautiously with feeding that patient. All right, and let's see, I'm going to take one last question. How do you address the hypocaloric feeding in the context of ICUs where as little as 65 to 75% of prescribed nutrition is actually delivered? That's an excellent question. I think hypocaloric feeding in the area of the obese patient and early on in feeding the patient in the ICU, the latest data is showing us that hypocaloric feeding is probably the way to go. Are protocols still important? Absolutely, for this very reason that we provide such poor feeding in the ICU space. So I think protocols are important. I think our goal is to try to advance feeding as tolerated over the first 3 days, and then try to reach that 80% mark with feeding. And in the obese patient that you're trying to feed hypocalorically for reasons of obesity, then you follow the guidelines where you feed 70% of measured according to indirect calorimetry. All right, so I think that was the last question. Those were wonderful questions, and I just want to thank you for having me today. I appreciate your participation today. And so on behalf of the Nestle Nutrition Institute, we hope that you found this information useful to your practice, and I hope you enjoy the rest of your day.